Bismillahirrahmanirrahim. Dear class, welcome back. We are the very first time we are starting this lecture online. The course is, as you all know, is emergency procedures and patient care. And today we'll be going through the learning objectives for today's lecture are we need to understand the respiratory and cardiovascular compromise, why this respiratory and cardiovascular compromise occurs, and what is its correlation in terms of emergency. Then we'll understand about sudden cardiac arrest and heart attack, screening and recognition of cardiac warning signs. What are the cardiac warning signs which can be recognized in case if a person is having these signs? Because sometimes the signs, they are silent. The person is having cardiac condition, an underlying cardiac condition. The person may be an active person, but still there is no actual presentation of the condition. Then we'll go through the preparation for cardiac emergencies, chain of survival, and we will understand the process of cardiopulmonary resuscitation, which is commonly known as CPR. So respiratory and cardiovascular compromise. When respiratory arrest occurs, the heart can continue to pump for several minutes. This is very important to understand. If a person has some sort of injury or becomes unconscious, we have already understood that because of unconsciousness, the tongue, it falls back and it blocks the airway, and eventually it leads to respiratory arrest. And many of the times, a person who is only having a respiratory arrest because of unconsciousness, if the airway can be opened by the techniques that we have understood before or learned before, the life of that person can be saved. But in case if the respiratory arrest is not managed at proper time, it will lead to cardiac arrest eventually. Stopping of breathing does not stop the heart. The heart continues to pump the blood into the body for several minutes. Eventually a time comes when because of lack of oxygen, the heart, it also stops the pumping the blood, and when there is no blood going to the brain, it will lead to brain death, and eventually the biological death it occurs. So without early intervention, respiratory arrest eventually will lead to cardiac arrest. Once the cardiac arrest occurs, circulation ceases and vital organs, they become deprived of oxygen, and brain is the first organ which is damaged by the lack of oxygen. And eventually what occurs is, if there is no respiration, eventually it will lead to cardiac arrest, and the condition is known as clinical death. The clinical death, it occurs when a patient is in respiratory arrest, that the patient is not able to breathe, or the patient is in cardiac arrest, that the heart is not pumping the blood into the vessels, or it can be a combination of both the respiratory arrest and the cardiac arrest. Brain is the first organ, as mentioned before, that gets affected because the lack of oxygen, and the patient has a period of about 4 to 6 minutes to be resuscitated without the brain damage. Clinical death can be reversed within 4 to 6 minutes. So these 4 to 6 minutes, sometimes the duration is extended to 8 minutes. They are labeled as the golden minutes in terms of rescue, even in terms of international rescue codes. These are the golden minutes in which, if the person's respiration can be restarted artificially or manually, or the heart can be compressed manually, the circulation will continue, and eventually this clinical death can be reversed. After 8 to 10 minutes, the brain damage, it occurs, and even if the heart is resuscitated and the patient is shifted to hospital, patient gets the cardiac support, inotropic support, still the brain death cannot be reversed, and the condition will be then labeled as the biological death. Sudden cardiac arrest in general population sudden cardiac arrest, as the name is telling, it is the cessation of heart's pumping activity. And as a result, there will be a lack of blood flow to the brain. It leads to unconscious in about 20 to 30 seconds. So whenever the heart is not pumping the blood into the system, the person will become unconscious in 20 to 30 seconds, and it will lead to decreased blood to the brain. When sudden cardiac arrest results in death, it is termed as sudden cardiac death. It is common in age group of 50 to 75 years of age, and overall survival rate is only 5 to 7%. So out of 100 patients who go through the sudden cardiac arrest, only about 5 to 7% of the patients can be saved. Sudden cardiac arrest, it also occurs in athletes. You must have gone through some videos on the social media or Facebook where some athlete is playing a game, and during the game suddenly falls and collapses, and next morning you come to know that the patient is, or that athlete is, no more. This is because of sudden cardiac arrest in athletes. It occurs within 1 hour of participating in sports. It may occur within 1 hour. It may occur on spot, or it may occur the person was actively involved in the game. The person completed the game. It was a vigorous activity. There were no signs during the game, and went back to his home or any other place. And 1 hour after participation of that sports or exercise, suddenly collapsed, and if the person collapsed, it will lead to sudden cardiac arrest. It is consistent with the low prevalence of cardiovascular disease in people younger than 35 years of age. So the condition is present in patients or people who are younger than 35 years of age, and they may be having an underlying cardiac pathology which was never diagnosed. They were actively involved in all type of activities and games and athletics, and one day this cardiac pathology triggers, and eventually it leads to death of that person. There is about 85% of the sudden deaths in athletes as a result of underlying cardiovascular condition. So most common cause of death in young athletes is sudden cardiac arrest. It has 4 further classifications. It can be ventricular fibrillation, it can be pulseless electrical activity, it can be asystole. Sudden cardiac arrest should be differentiated from a heart attack. As we know, in the normal pathophysiology or pathology of heart attack is the patient initially has angina, which is lack of blood flow to the heart tissue because of collapse of artery or blockage of arteries, and then it leads to myocardial infarction or heart attack. Whereas in case of sudden cardiac arrest, there is sudden cessation of cardiac activity, which may be due to electrical or mechanical component. First type is ventricular fibrillations, most common rhythm abnormality occurring in about 60% of the cases when assessed by an on-site automated external defibrillator. So when a patient suddenly collapses during a game or during an activity, or within 1 hour after playing an activity, collapses, and luckily if the automated external defibrillator is available and the automated external defibrillator is applied, the life of that person can be saved. These persons, they respond quickly to the defibrillation. A high energy shock which is delivered to the heart, survival rates are as high as 74% when defibrillation occurs within 3 minutes of time of collapse. So when the patient collapses, if within 3 minutes the automated external defibrillator is available and is applied to the patient, that automated defibrillator will identify whether person needs the shock or not, will deliver the shock, and if the shock is delivered within first few minutes, the life of that person can be saved. Second type of sudden cardiac arrest is pulseless electrical activity. The term used for other electrographic ECG rhythm, including normal sinus rhythm, when there is no associated cardiac contraction. So there will be an absence of electrical activity, which will lead to pulseless electrical activity the condition. It responds to treatment when a reversible condition that causes such as hypovolemia or hypokalemia. So in case of pulseless electrical activity, the normal pacemaking activity of the heart is present, but due to an additional condition, which may be hypovolemia, the person may be having hypovolemia because of dehydration. He was extensively involved during the game. There was a complete washout of the electrolytes and from the body, and it led to a hypovolemic condition. There was excessive sweating. The person may be dehydrated, was not taking proper hydration during the activity, or was taking only a plain water. So there are multiple factors which may lead to, even in the presence of electrical activity, the pulse it becomes absent, and it will lead to mortality, and mortality from this condition is higher as compared to ventricular fibrillations. Finally is asystole, which is absence of cardiac electrical activity. Therefore, the absence of any mechanical cardiac function. Patients found with this rhythm have poor prognosis, with most studies reporting survival of only 0 to 2%. So there is absence of cardiac electrical activity. The normal pacemaking mechanism of the heart is blocked, and as a result, when there is no electrical activity, no pacemaking activity, it will lead to stopping of the mechanical pumping of the heart, and patients who develop asystole, the survival rate is only 0 to 2%. Preventive measures. Now, there are certain preventive measures which, if taken appropriately, they may help identifying the underlying condition at appropriate time. And if certain measures are taken, the patient can be prevented from some certain activities and exercises, and the life of that person can be saved. So most important is screening. There's another term which is gaining popularity, and especially in current situation, is public health. So one of the key component of public health is screening. All the individuals, whether they are healthy or they are having some sort of chronic condition or disease, they need to go through a screening process. At certain age, the screening process should be started. All the high-risk patients, suppose if a patient is having diabetes, hypertension, history of diabetes, hypertension, and cardiac abnormalities or pathologies in his family, he or she should be, even if he is having no symptoms, should be screened at least once or twice a year, so that any problem which is arising, or because he is at a high risk of developing that condition or disease. So screening every person who intends to participate in vigorous physical activities, especially the competitive sports where there are high impact sports like rugby or sports or like football, they should receive, they should go through a thorough screening process for cardiovascular diseases and other diseases. And preventive measures, they also include the recognition of cardiac warning signs. The persons who are involved with the athlete, maybe the other athletes, maybe the trainer, maybe the physical therapist or the doctor or physician, they should be able to identify the cardiac warning signs. There are always certain warning signs which are present before the occurrence of an event, and they may include syncope, they may include palpitations, episodic or exertional dyspnea. The person may be more fatigued as compared to other players of the same team. After doing certain physical activity, may be more fatigued, may start having increased heart rate, may complain of palpitations or heartbeat abnormalities, may complain of exertional chest pain or having the it's not always a chest pain. It can be a tight band which is blocking the chest. It can be uh, the pain may go into the chest, the pain may go into the jaw, into the shoulder, into the arm. So all the warning signs uh, should be identified. And in addition, there can be early fatigue also. The person may be fatigued as compared to other team players. And differentiating the sudden cardiac arrest from the heart attack can be due to acute myocardial infarction. And it usually occurs when there is a blockage to the circulation of the heart in many of the artery which is supplying the heart muscles. Most common causes are coronary heart disease. Again, it is a genetic predisposing factors are there, and it is a genetic disease which travels from parents to the offspring. So any patient who is having a high risk of developing the heart attack should be monitored and screened. There are certain modifiable risk factors, and there are certain non-modifiable risk factors. The family cannot change. You cannot change your parents. Although there are some reported instances, but in most of the cases, the sex can be changed. You cannot change your gender. Age cannot be changed. Your ethnic background cannot be changed, and with certain ethnic backgrounds, there are certain chronic conditions which are linked to these ethnic backgrounds. And most of the time, society and culture cannot be changed also, because the society in which we are living, if they are having bad eating habits, they are having less interest in physical activities and exercise. So this culture will, these are mostly non-modifiable risk factors. And then there are modifiable risk factors which can be changed, include smoking, high blood pressure, high cholesterol, physical inactivity. So these are all the factors which can be controlled, which can be modified. High blood pressure can be controlled. As a result, there will be less pressure over the heart. High cholesterol can be controlled. There will be less plaquing of the arteries because of, or vessels because of the higher cholesterol. And physical inactivity, it can also be changed if the patient starts doing more and more physical activity. The chances of having the cardiovascular condition, they can be delayed. And in case if the condition is already existing, the physical fitness level of the person can be improved, and the life expectancy can be increased also. So the recognition of cardiac warning signs, as I mentioned before, there can be jaw pain, there can be chest pain or shoulder pain, not necessarily only the left shoulder pain. It can be or left arm pain, as there is a common misconception. There can be neck and arms and back pain. Patient may also feel nausea, vomiting, which is not related to any other illness. There can be dizziness or lightheadedness. There can be syncope. There can be cold sweats, shortness of breath, palpitations, fluttering in chest, fatigue, weakness. So any of these are the cardiac warning signs, and patient and the players who are working with that athlete, or the trainers or the coaches, they must be familiar with these athletes. And if a person is repeatedly or complaining of these problems, then they should be screened for any underlying cardiac pathology. Now comes the most important part, which is the chain of survival. And the chain of survival, it is the major part which will be able to save the life of that person. There is successful resuscitation of the victim of the sudden cardiac arrest, heart attack. It requires proper interventions to be provided in a very short time. The chain of survival has 4 links. Each link is very important and integral in terms of saving the life of that person. Patient's chances of surviving are the greatest when all the links they are joined, or they come together, or they are offered at an appropriate time. They include early access, early CPR, early defibrillation, and early advanced care. So these are three components which, if given at appropriate time, or four components which given at appropriate time, they will be able to save the life of that person. So first we understand the early access, recognition of sudden cardiac arrest, heart attack, and preparing for CPR. In case there is an early recognition, there will be establishment of need of resuscitation. You approach the patient is complaining, or the client or the person or athlete is complaining of the cardiac warning signs, and you establish the need of resuscitation, whether this person needs cardiopulmonary resuscitation or not. Determine the level of responsiveness. You need to recall the levels of responsiveness, which we have already understood, and there are four levels, which are alert, verbal, painful, and unresponsive. So determine the level of responsiveness. If the person is unresponsive, and again, if we recall that any person who is unresponsive is unquestionably in need of airway management. No matter what is the condition, whenever a person is unresponsive, that person needs the airway management. Then, if the level of responsiveness is established, activate the medical emergency services, and you have to call rescue 1122 and inform them about the condition of the patient. If you have other bystanders and other persons who can also act as medical first responder, then you will continue to assess or evaluate the patient, and the other person can make a call, so that the golden time which is there to save the life of that person can be utilized. Check the ABCs, and you have to manage the A is for airway. You have to manage the airway. Then you have to check for the breathing, whether the patient is breathing or not. If the patient is not breathing, then there is a respiratory compromise. Then you check for circulation through checking the pulses. It can be peripheral pulse, or it can be a carotid which can be identified. And if there is no pulse, the person is having a cardiac compromise, or person may be having a combination of both the respiratory and cardiac compromise. Open the head, open the airway. Usually there will be no history or suspected cervical injury, so we can go with the head tilt and chin lift maneuver. If you recall, the other maneuver is jaw thrust maneuver, which is used when we are suspecting a cervical injury. But in case there is no cervical injury, we can go with the head tilt and chin lift maneuver. For suspected cervical injury, we'll use the jaw thrust maneuver. And the best method is approach the patient from the right side in a kneeling position. Apply the principle of look, listen, and feel. Look for the rise and fall of the chest. Listen to the breath sounds. Try to listen to the breath sounds which are coming for the air which comes out of the mouth, and try to feel the warmth of the air with your earlobes. The practice will be done, or I will upload the video in which this approach can be determined appropriately. And if the person is not breathing, or if you identify that person is having a respiratory or cardiac compromise, you'll go with the rescue breathing. Now, with the rescue breathing, if we recall, if there is no breathing only, you give 8 to 10 straight rescue breaths and then reassess. And if still there is no breathing or no pulse, you start with the cardiopulmonary resuscitation. So next process is cardiopulmonary resuscitation, or CPR. CPR it's the combination of chest compressions and artificial ventilations. It is designed to revive the person and prevent biological death by mechanically keeping the person's heart and lungs working. Now, the question which has been raised before, that or sometimes what happens is the person may be having injuries and maybe having facial injuries, maybe having bleeding from mouth or surrounding areas. In these cases, sometimes it becomes difficult for the rescuer if he or she does not have the facial mask or the BVM or other supports which can give artificial respiration. Then the only choice is mouth-to-mouth ventilation, which again is legally also covered, whether it's up to the will of that medical first responder if he or she wants to go with the mouth-to-mouth ventilation or wait for the emergency services to arrive, because the rescue services, they have the bag valve mask, or commonly called as ambo bag, or and other barrier device masks which can be used for respiration. One more point to mention is the normal air that we breathe, it has about 21% of oxygen, and the air that we exhale, it has around 16% of oxygen. Save the life of the person who is not breathing, because that person is having 0% oxygen, and through rescue breathing you are giving about 16% of oxygen through your exhaled air, which is still sufficient enough to save the life of that person. The goal of CPR is to prevent the biological death and reverse the clinical death, and for a few crucial minutes, because it cannot be done for longer duration. You need to have advanced life support for longer duration, or patients having needing longer duration of CPR. You can only perform within first few minutes, the golden minutes, and save the life of that person. The patient condition needs to be monitored through CPR to determine if the CPR is effective. So during the CPR, if you are giving the chest compressions, there should be a pulse felt, because with every compression, the heart is compressed. When the heart is compressed, there will be a peripheral pulse which can be palpable, or a carotid pulse which can be palpable. If during the chest compressions there is no pulse palpable, it means the compressions are ineffective, or you're giving the compressions on an area where it's not appropriate, or it's not the right site to give the chest compression. Chest compressions, they consist of rhythmic repeated pressure over the lower half of the sternum. When combined with the artificial ventilation, it provides enough blood circulation to sustain the life. So as I mentioned before, that if you are only left with the option of mouth-to-mouth rescue ventilation, then it's up to you to go with the ventilations or do not go with the ventilation, because of the risk of other disease contamination or disease transmission from that injured person or unconscious person. In case if you do not wish to give the rescue ventilation, you can continue with the new approach is you can continue with the chest compressions only, because with the chest compression, still some amount of air exchange is mechanically possible at the levels of lungs. But you need to position the patient accordingly, and most of the time when the chest compression and ventilation, it is combined, it is enough to provide blood circulation to sustain the life of that person. So you need to position the patient. Patient may be in side lying position, maybe in prone lying position, should be in supine lying position or facing up, or patient should be lying on his back. And for that, certain specialized maneuvers can be used, which are log roll method, which can be used to make or to turn the patient into supine lying position. Next thing is expose the patient's chest. And while managing the airway, we have already understood that you need to cut off the clothing which is blocking the airway. You have to loosen the tight clothing. If it is blocking the airway, you have to position the patient head into using head tilt and chin lift maneuver, so that the airway is open. And once the airway is open, you will expose the chest of the patient. In case of male patients, you can cut off the shirt. There is no time to remove the shirt. You can cut off the shirt. If it is a zipper, you can unzip the shirt, in case of male patients only. But for female patients, considering the ethical consideration and their privacy, we try to minimize the clothing, but the privacy of the patient is also respected. So you get in the position, you approach the patient from the right side, you in a kneeling position close to the patient's right side, body is centered to the patient's sternum, and your knees are about as wide as your shoulders are apart. Then you locate the compression site, place your hand at the center of the chest, forming an imaginary line between the nipples that joins both nipple of the patient. Position your hand. For adult patients, put your free hand on the top of the first hand and extend or interlace your fingers. Do not rest them on the chest wall. So you have to interlace the fingers. And for children or infants who have a rather small chest, you can use only 2 to 3 fingers to give the chest compressions. Your shoulders should be, your elbows should be extended, and shoulders should be over your hands. So the placement of the hands is important. Elbows should be extended, shoulders should be on the top of the hands. That means you'll be able to use your body weight for giving the effective chest compression. To start with the chest compressions, keeping your arms straight, your elbows lock into extension. Thrust straight downwards from the shoulders. Release the pressure completely after each compression, but do not lift your hands from the chest, because then you will lose the compression site. So you have to keep your just lift off the pressure, but do not lift off your arm. So this is a graphical presentation. One hand is placed on the imaginary line between the nipples, and other hand is interlaced. The fingers are interlaced. The position of the hand cannot be changed. You provide an effective compression, and then you lift off your pressure only, not lifting your arms. Adult CPR summary, 8 years and older. Now, there are 2 types of age groups. One is less than 8 years, and other is 8 years and older. The compression depth is around 4 to 5 centimeters, or it is around 1.5 to 2 inches. That means when you are compressing, you have to compress up to 2 inches. The chest has to be compressed up to 2 inches. Compression rate is around 100 per minute. There are 60 seconds in a minute, and you have to give almost 2 compressions in a minute. So that should be monitored. If and with each compression, you have to count also. You can count also, and usually each ventilation should be of 1 second. If one rescue cycle, if you are the only person who is available to give the emergency, there can be 30 compressions and 2 breaths. That means you will give 30 compressions, and then you will lift off your hands from the chest wall. You will move towards the arm, and you will give the rescue breaths. 2 rescue breaths should be given. If there are 2 persons, one person will continue with the chest compression, whereas the other person will give the rescue breaths. There will be 15 compressions and 2 breaths. Now, the other category is less than 8 years of age. Compression depth is slightly decreased. If you remember, for adults, it was 4 to 5 centimeters, and for children under 8, it is 3 to 4 centimeters, because they have more flexibility and less diameter of the chest. So 1/3 or 1/3 of the total chest depth. Compression rate is again 100 per minute. Each ventilation should be 1 second. And again, one rescue cycle is 30 compressions followed by 2 breaths, and 2 rescue cycles are 15 compressions followed by 2 breaths. In case of infants under 1 year of age, cardiac arrest in infants is rarely it is caused by heart problems, and usually the cause is hypoxia. And if you remember, we understood that in case of infants, the most due to respiratory compromise, and in case of infants, the most common type of respiratory compromise is twice. The infant, they tend to catch everything that is handy, and they tend to put it into their mouth. So most common is twice. Other possible causes of respiratory compromise can be injuries, there can be suffocation. Again, it mostly in the home-based environment. There can be in case of smoke or in case of fire incidents, or smoke which is being collected after some fire incidents. There can be a smoke inhalation that leads to respiratory compromise. Resuscitate an infant for 2 minutes before activating the EMS. So they have a good chance of being resuscitated if there is only one rescuer before activating, but their brain is very fragile. They are more sensitive to lack of oxygen. The brain is in a developing phase, so you have to first resuscitate and then warn the EMS if you are the only rescuer on site. If there are multiple rescuers or there are other person who can call the rescue, they can call the rescue, and you can continue with the resuscitation of the infant. So for infant, the size of the infant is small. You can place him or her on your forearm, using your palm to support the head. Expose the chest, locate the compression site. Compression site is just below the nipple line. Perform chest compressions. Use flat part of your middle and ring fingers to compress the sternum. Release pressure completely after each compression. Do not lift or move your hands. You will lose the proper position and the compression site. Count as you perform the compression. So the compression can be 1001, 1002, 1003, 1004, 1005, 1006, 1007, 1008, 1009, 1010, 1011, 1012, 1013, 1014, 1015, 1016, up to 20. And then you give the rescue breaths and then restart the process. So this will be the positioning of the fingers. You do not need to place the complete hands or both hands. For infants, the effective chest compression can be given using 2 fingers only, or the thumbs of both hands in case if the position is properly maintained. This will be an imaginary line between the nipples. For infants, you tend to select the position, the side which is slightly lower this line. This will be the probable position of their heart. Compression depth is 1.5 to 2.5 centimeters, or 1/3 or half of the total chest depth. So whatever is the total chest depth, you can compress so that half of the chest is compressed and half of its width is compressed. Compression rate is again 100 per minute, or it can be more. Each ventilation is 1 second, and usually it will be a 1 rescue cycle because the size of the infant is small. But in case if there is 1 rescuer, you will be giving 30 compressions and 2 breaths, and 2 rescuers, you will be giving 15 compressions and 2 breaths. And if you remember, for adults giving the rescue ventilation, the appropriate method is pinch the nostrils, position the head into where the airway is open the mouth, and give mouth-to-mouth rescue breathing or other methods. In case of infants, you place your mouth, because the size of the mouth is so small, you place your mouth over the nose and mouth at the same time, and rescue breaths can be given. For newborns, 3 compressions, 1 breath, 3 compressions, 1 breath, 3 compressions, 1 breath, because their brain is very sensitive to lack of oxygen, so they need more oxygenation as a result. Signs of successful CPR. I was just going, the successful CPR does not mean that the patient survives. It only means that you performed it correctly. Very few patients will survive if they do not receive advanced cardiac life support. So there is an underlying cardiac pathology. If the cause was only mechanical, you have removed the, or if the cause was only foreign body airway obstruction, you have removed that obstruction, the CPR will be successful, the person may become normal. But in most of the cases, if the person is already having some underlying disease or condition, the patient needs to be hospitalized, where the patient will be put on to advanced life support system. And it can be an inotropic life support through certain medications and drugs which are administered to the patient, or it can be an artificial breathing or a combination of both. So patient needs advanced life support. Have someone feel for pulse during compression. A pulse should be palpable with every compression. Now, signs of successful CPR, whenever you are compressing, the pulse should be palpable. If you are compressing and there is no pulse palpable, it means the heart is not being compressed. You are compressing at the wrong side. So you need to change the position of the head, of the hand, and with every compression, the pulse should be palpable. With the ventilation, the chest should rise and fall. If there is no movement of the chest with the rescue breathing, it means that you did not perform the procedure effectively, efficiently, or rightly. The pupils may begin to react normal. In case of infants, the child color from bluish color, it starts turning into a more pink or reddish color, the color of the skin. In case of adult, the pupils, they may start to move or they may start to react normally, and patient's skin color may start improving with the successful CPR. Eventually, the patient may attempt to move his arms, his body may attempt to swallow, may regain consciousness, and may try to produce some body movements. When not to begin CPR, you reach at the site, the person is unconscious, there is nobody to tell you, or if certain time has passed, you will not start with the CPR. Obvious mortal wound. There is an abdominal injury, massive bullet injury which has busted the brain, or severe abdominal injury. The organs are protruded out. There is massive bleeding from that wound. So there is an obvious mortal wound, and the life of that person cannot be saved because the bleeding cannot be stopped. So you will not start with the CPR. Livor mortis or rigor mortis, the stiffness which is associated with the death or the color of death, which has a certain characteristic presentation. We have gone through these details before. Decomposition, the body has already started decomposing. The fluid is oozing from the nostrils or mouth, so there is no need. A stillbirth, the child who was born without breathing, was born blue, a stillbirth, no movement, no breathing, and this chances of survival are very poor. Complications which may be caused by the CPR, even properly performed CPR, it can cause injuries. It can cause fractures of the sternum and ribs. I've gone through a news where a passenger in the aeroplane was resuscitated, and the resuscitator was ended up fracturing his 3 or 4 ribs. But the fracture of the ribs is at the cost of saving the life of that person. So it may be an associated complication, fractures of the sternum or ribs. Pneumothorax can be there. The rib, it fractures, it goes into the lung, it ruptures the pleura, it enters the air into the pleural cavity, and the condition is known as pneumothorax. There may be bleeding into the pleural cavity, which is known as hemothorax. There can be cuts, bruises to the lungs, lacerations to the liver. Alternative to complications is death. Remember, alternative to these complications is death. You are performing the CPR rightly, there can be associated complications, but alternative to these complications is death. So there is always a choice that has to be made, and the choice is always saving the life of that person. Mistakes in performing the CPR. There are certain mistakes which can be there in performing the CPR. Patient is not on a hard surface. Patient is lying on a mattress. The chest compression cannot be effective. Patient is not in the horizontal position. The head side is raised. What will occur? Even if you are compressing, the blood will not go to the brain. And as a result, head is higher than the rest of the body. The blood will not go to the brain. Third, head tilt chin lift maneuver is improperly performed, or jaw thrust maneuver is improperly performed. So what happens? The airway is not open. With the blocked airway, you're pushing the air into the lungs, trying to push the air into the lungs, and there is no air going into the lungs. Nostrils, they are not completely pinched at the patient's mouth, is not fully open during the mouth-to-mouth ventilation. If the nostrils are not pinched, you push the air from the mouth, it will come out from the nostrils. So ventilation is not effective. Ventilation is not effective. Pulse is not palpable. The person will not survive. Hands, they are not in correct position. Compression, incorrectly placed. Fractured ribs हो जाएंगी, fractured sternum, lacerated liver, spleen, lungs, injured pleura as a result of fractured ribs. Compressions too deep or too frequent, there will be insufficient amount of time for saving the life of that person. Compressions are too deep, the heart does not get the chance to be refilled. Improper compression or ventilation, eventually there will be inadequate oxygenation of the blood. And finally, if you perform the CPR effectively, as we mentioned before, still the person needs advanced life support. You can only save the life of that person till the time the rescue services arrive. And once the rescue services arrive, they will take over from you and they will start performing their procedures. The patient may be needing defibrillator, the patient may be needing artificial respirators or ventilators for artificial breathing. There needs to be communication with the rescue services, and in case of defibrillators, patient at the hospital will be needing manual defibrillators or automated defibrillators. Manual, they always need a doctor or physician to be present on the site and will identify the rhythm abnormality in the ECG, and then will decide whether the patient needs defibrillation shock or not. Whereas in case of automated defibrillator, there is an automated process. You apply the patches and you wait for the machine to analyze, and once the machine analyzes, it decides whether the patient needs to be given the electrical shock or not. So here is the detail of manual defibrillators. They are used by medical persons only. It requires understanding of ECG rhythm, and user should be able to set the energy level, activate the charging process. In case of automated defibrillator, they can be used by anyone who only has the understanding in how to place the electrodes and where to place the electrodes. And they provide verbal clues, they provide visual prompts to the users, and they even provide the verbal clues that the patient needs an electric shock, and further guide how to perform the electric shock. Some models, they require users to push analyze button. They are semi-automated type, and then shock button, whereas some perform analysis, charging, and shock delivery without further user interaction. They are fully automated. So here is a presentation of how the AEDs will be applied. One patch will be applied around right clavicle, other on the left side of the chest. You start the push button, and rest will be done by the automated external defibrillator. Then the patient may be needing ventilatory aids, may be needing a respirator, and simplest ventilatory aids can be a face mask or face mask with a shield, which will be used to give the manual ventilation. So with this, we conclude the lecture. If you have any questions or comments, you can join the Google Classroom. That the link has been created there, and you people have been added in that Google Classroom. And I'll be available during my class timings at the Google Classroom. And any questions regarding this lecture can be answered there. Thank you for joining.